Our Healthy Men is a presentation of the Prostate Cancer Coalition and Rare Gem Productions. The Prostate Cancer Coalition is a coalition of healthcare providers and survivors in the St. Louis region that have come together to advocate smart screening for African American men and men with strong family histories of prostate cancer. The Prostate Cancer Coalition supports the idea that there should be a discussion about the risks and benefits of screening, beginning at the age of 45 for African American men and younger if there's a strong family history. We're here to answer your questions and provide you with solutions and especially options. We want to see you thrive, and we want the best for you, our healthy men. And welcome back, Our Healthy Men, the Prostate Cancer Question and Answer Show. I'm producer Jade Harrell, and we have our hosts with us yet again, Dr. Lannis Hall and Dr. Arnold Bullock.
Hi, Jade.
Hello. Welcome back. We are bringing this program to you, brought to you by the Prostate Cancer Coalition as a courtesy of the Siteman Cancer Center, as well as the generous contribution of the Foundation of Barnes Jewish Hospital. And so we are so glad to be with you, and we're going in deeper, even more, into our conversation about prostate cancer. This time we're talking about the actual diagnosis. Now, we've talked about screening, we've talked about clinical trials, we've talked about what the prostate gland does, but then how do you diagnose prostate cancer? Well, we happen to have just the right guy in the house and the right lady in the house, and I would love for you all to share with us some background about how you came to diagnosing, where you had to share the news.
Well, when I was a small, young pup.
That wasn't very long ago.
It seems like a babe. I was just a babe. I was a surgery intern at Howard University.
Oh, wow. Howard, the other HU.
Yeah, and they sent me down to the emergency room, and they said, there's a gentleman, he was brought in by his family. He's not been eating. He's in pain. And I went down, and I actually was interesting because I actually was in my first month,
wow,
right after medical school. So I wasn't exactly sure. Let me just do a thorough physical exam. Well, he was in a fetal position.
Oh, my gosh.
And he was in pain. He was writhing in pain, and he hadn't eaten in days. So we sent off a panel of blood, and I did an exam, and it was my first prostate exam. And I was like, I should feel like a rock. It just felt like I was palpating a rock back there. And I didn't quite know if that was the way it was supposed to feel. So we sent all this blood that we've talked about before off, and his PSA came back over 1,000.
Oh, my.
And he had a bone scan, and he had what we call a super scan, where every bone was lighting up like a Christmas tree. We had a biopsy, and Dr. Bullock will talk about how we do that. So he had metastatic prostate cancer. So this was back in 1992 when I first...
Welcome aboard. That's a way to get started.
I'll never forget it.
Right, right. So how did you respond to that? What did that teach you?
Well, first of all, I started reading on the blood test because everybody said, his PSA's over 1,000. And at the time, PSA shouldn't be over 4.
4, right?
4. And so I realized what an amazing test to have, that you can check on a cancer, and he didn't have any problems passing his urine. That wasn't his complaint. He had bone pain.
Right.
And so that was my introduction to the PSA, a biopsy, how a prostate feels on examination.
Exactly. Well,
an abnormal prostate gland feels on examination. And so now we're here talking about the importance of PSA.
What was your experience, Doc?
I've diagnosed prostate cancer in so many men.
Do you even remember your first? Early?
I don't remember the first because I was involved as a junior resident in the prostate cancer screening study at WashU, the PSA study, which ended up having 50,000 men in it. And so we got a little extra change from the division if we would agree to come in and do exams as part of the screening study. And so there were so many men in the study. How do you do rectal exams and PSAs every 6 months on tens of thousands of men.
Right.
You have to hire the nurses and the residents to come in on Tuesday and Thursday nights and do it.
Absolutely.
And so we thought, like $25 an hour was pretty good. And so that's what we did. But there was thousands and thousands of men that we examined and biopsied as a resident when I was doing my training. So this whole change in PSA happened in the late 80s, early 90s. And so it's, as we mentioned in previous shows, it has changed the face of prostate cancer and our ability to pick up men far earlier than the tragedy that Lannis just described.
Lives.
So 2 key things. Most people with prostate cancer have no symptoms of their prostate cancer.
Right.
So the diagnosis is first best made as a result of you getting screened for prostate cancer. Screen means you have no symptoms. You don't have bone pain. You're not in a fetal position.
Yeah.
And you go to your doctor, Doc, what should I be getting done at 40? What should I be getting done at 50? And one of them should be a blood test called a PSA. You get your blood test. At the same time that you're seeing your doctor should have discussions of lung cancer and colorectal cancer. And being a thorough doctor, he should examine your prostate if you're over the age of 40. If he feels your prostate to have a nodule or irregularity, that's worrisome enough for cancer that usually warrants a biopsy. 50% of people who have a palpable nodule actually have prostate cancer on a biopsy. It's more diagnostic than even an elevated PSA. Your prostate exam is benign, but your blood test comes back above 4. Person could consider other options like a 3T MRI or other tests to look at variations in the PSA to see, do you more likely or less likely have prostate cancer? But usually the person who comes in first time with an elevated PSA, we send another PSA to confirm the elevation. You're confirmed to truly have a PSA above 4. Honestly, I recommend that person first get a biopsy. What is a biopsy? A biopsy is a procedure that urologists do in their office. Every day I'm in clinic, I do a biopsy. And so on a given Tuesday or Wednesday clinic, I probably biopsy 5 people.
What does that entail?
And before you get on to how you do the biopsy, can you talk a little bit about age? Because I wonder if someone who's 70 years old and has a PSA that's 4 is as meaningful as someone who's 40 years old who has a PSA of 4 and a small gland versus a larger gland. So is there anything else about that PSA with regard to age and
that is exactly
size?
Right. You know, the PSA, this number of 4 is kind of an arbitrary number. It's not that 4 is some magical number. So as you get older, your prostate tends to grow and your PSA tends to go up some. So one of the key points on PSA screening is you should know your number. You should know your cholesterol, right?
Okay.
Know your number.
If a brother knows that his cholesterol is running 250 and they go to Weber Grill, maybe he should be thinking, I like Weber Grill, but maybe I should get the full slab of ribs 3 times a week because my cholesterol's high. You get what I'm saying? Maybe he needs to realize that he needs to eat more vegetables, be more prone to get some salmon. He knows
shouldn't have that.
You don't want him to have the ribs 3 times a week.
That's the point, that he knows his cholesterol is high. And because he knows his cholesterol is high,
he takes
that gives him the knowledge base to better manage his health care. Not someone telling him what to do, but he knows his cholesterol is high.
Right.
He got a choice. Maybe you need to eat something less fatty on a regular basis.
Sure.
If you knew your PSA. So many times a person picked up the best is a man who comes in and his PSA was 0.4 at 40. And then at 45, it's 0.9. Then at 50, it's 0.9. But 52 is 1.8. 53 is 2.7. 54 is 3.8. It's technically not above 4.
That's not good.
However, knowing your numbers and watching the change from exam
it
to
shouldn't
exam,
do that.
Right,
should not be right.
So long,
gives you a good indicator
before
too.
It's 4. That guy probably would have had a biopsy when it's 2.7.
Right,
right. It went
Like
from
look,
0.6,
right,
and then 1.7, now 2.6. God,
Something's going on.
Forget the 4.
Forget the 4. Right.
I bet you have prostate cancer.
Right.
That's right.
And on the other hand, I get referred men all the time like
yes,
that.
Sir.
And I don't, it's good that they come in. We can discuss it so we get a comfort level for the patient. But when I get a 79-year-old guy who's on oxygen rolls into my office and his PSA is 4.2,
do you even buy it? I hope you're not even buying it.
I'll say, sir, you know what? I think you're doing just fine. Because prostate cancer is something that develops and progresses over the course of years and years.
Yes.
We can monitor that guy. He's not having symptoms with the way he urinates. His prostate feels benign.
Right.
We could check his PSA once a year or every 6 months.
But you did include that his prostate felt benign. If that's
right.
Exactly
so
right.
between the PSA and the biopsy, have an exam to see what things are feeling like.
That's
because with prostate cancer, again, not having symptoms until you're well into the thing.
We don't want any symptoms.
We don't want any symptoms because then we know we've got a real problem. It all is resolved in the screening and what you're doing ahead of time and knowing your numbers.
Yes.
That's correct.
That's fantastic. So it's not cancer specific, this PSA. It's
That's right.
organ specific.
It's organ specific.
Let's go into that a little bit more.
Well, it just means that when you have a PSA, it's taking into account the benign tissue in the prostate. And let's say you have a prostate cancer, it's also taking into account the cancerous tissue. So it is specific to the organ, which means if you've got a big prostate gland and a lot of benign, what we call prostatic hypertrophy, meaning a lot of glands are in the middle of the gland that are getting larger and larger and secreting PSA, your PSA could be 12. But you don't have prostate cancer. You just got a huge prostate gland. And some men
and then we go back to needing that
digital rectal exam, but then that's also when it's important to have maybe some other tests done to confirm, is that elevated PSA due to a concern about cancer, or is it, you just got a huge prostate gland?
I love when you say huge.
Because some men have, I'm telling you, I've had men who come in, their prostate glands are bigger than an orange. They're absolutely, they're large.
And that doesn't necessarily mean you have prostate cancer.
No.
And as we've learned in previous episodes, is that as men age, their prostate glands enlarge.
That's right.
Okay, so they earn them a little maturity as they as they go. But I think one of the great realizations here is that there are additional tests.
Yes.
And there are additional tests that can come between the PSA and knowing more information, but that is one of the best places to start.
Right. So I would like to hear about the biopsy.
Oh, boy.
So
tell us about
that. Tell us about the biopsy and how many cores you should have, and what is a core?
What's a core?
So that's right. So people hear about their cores. So, the biopsy is done since 1992 using an ultrasound.
Okay.
And we put an ultrasound probe in the rectum. An ultrasound is a sound wave. It's like a radar. But the ultrasound probe is about the same length and diameter as your finger. In fact, some people find that ultrasound probe is less intrusive than the finger because the finger has knuckles. An ultrasound probe is smooth; it slides right in like butter, And so you.
He makes it sound so good. That probe goes in like butter.
So
sign me up now.
You loop this probe up real good, and you slide it in, and you can see the image of the prostate in different planes on the ultrasound, and you can look and see if it's symmetrical. Is the right side the same as the left? You can look at the seminal vesicles, those structures that we talked about that are attached to the prostate that contribute some of the elements in the semen, and you can measure the volume of the prostate. So once you have the prostate, nicely imaged on your screen, you can use a needle that's the same diameter as the needle used to give a TB shot. We all get the TB test under our arm, a little thin little needle. That needle can go in and numb up or anesthetize the rectal wall that sits in front of the prostate. We have less sensation in our rectum than we do in our hand. So if it comes to an anesthesiologist wants to put an IV in me and he goes in my hand, I'm going to move my hand out the way. I'm like, brother, you're going to do it in my arm because my arm will be less sensitive than my hand.
Sure.
And my rectum should be less sensitive than my arm.
Okay.
So this numbing medicine is not something that should make someone make any noise over. Many people say, Yeah, I think I can feel a little burning down there. Once the rectal wall is numbed up, we can take the cores. We use a needle the same diameter as what's used to routinely draw blood in order to take samples. Years ago.
Now, the samples are the cores?
The cores, little small slithers.
Yeah.
Years ago, we would take 4 samples. Initially, we took 4 samples total. But they used true cut needles, like a big needle.
Yeah.
So if you were going to try to, I don't know, hit balloons on the wall at the circus, which would you rather, a big dart or a lot of small darts? The more small darts you hit, the more likely you can hit more balloons, as opposed to throwing 2 big darts.
That makes sense.
And so the more anesthetized the prostate is, the more ability you have comfortably to take 6 cores on each side without much fuss in order to do more sampling. The more darts you throw, the more likely you're going to hit more balloons.
Okay. So you come away with 6 cores or 6 samples.
12.
6 on each side.
You said 6 on each side, so you got 12 cores.
Okay.
Okay.
And
so with the 12 cores, then they come back and you...
And it's a map. So because we want to know where each core came from, and if it's going to come back positive, I really want to know, where is that core positive? Is it on the right? Is it on the left? Is it at the apex of the gland, or is it the mid gland, or is it at the base? So, they actually have a map of each core. And we will then have the pathologist review the specimens under the microscope, and for each core they'll say, is it prostate cancer or not? After they make that decision, they give it what we have typically called a Gleason score. We're changing that system, but we call it a Gleason score. And that score, it's a value system from 1 to 5. It's an architectural presentation. It's how it looks under the microscope. So if it's a 1, a very low score, then that means it looks almost like the normal prostate tissue. This is a gland, well circumscribed, very orderly. And so,
don't you love how she
that's right. I'm making me smile.
Right. So that's 1.
It's art for her.
But then by the time you get to 5, because the scoring is between 1 to 5, you can't even tell it's coming from the prostate gland. It's sheets, it's stroma, it's tissue, it's connective tissue. There's no glands that you can really say are organized. So most men, luckily, don't have a 5, because that actually corresponds to a very aggressive growth pattern. Most men are presented with a 3, right in the middle. We don't even see 1 and 2 anymore. I haven't seen 1 and 2 in, 15
years.
Normal. So the new normal. So that's your first score. Many men have 2 growths going on. They have something in the background. And so the pathologist says, well, I see mostly 3, but then I see a little more disorder in the background, and so it's a 4. So then the score is Gleason score, 3 plus 4 equals 7. Because 3 is what you see the most of, 4 is what's in the background, and so the score is a 7. And believe it or not, 3 plus 4 is very different than 4 plus 3.
Oh, boy.
And then 5 plus 5. But the point is, each core has a separate score.
You know what I tell? I always come up with these analogies.
I love the analogy.
So this is what
She's my artist, and you're my storyteller.
So let me tell you my
analogy.
So a guy comes in, Doc, I don't understand this Gleason score. I'm not getting that. Why is 3 plus 4 different than 4 plus 3?
Yeah.
Simple. I say, this is the deal. You're walking down one of the side streets in New Orleans. You made a mistake. You're about 4 blocks off from Royale. And you see 3 brothers come around the corner. They don't have to be brothers, but everything is brother. 3 brothers roll around the corner. And you try and decide how bad I'm going to get beat up tonight. And so one guy has a knife and 2 guys don't have a knife. Which would you rather? 2 guys, no knife, 1 guy with a knife versus 2 guys with a knife and 1 guy without a knife. I'll take the 1 guy with a knife and 2 guys without the. You know what I'm saying?
So now I'm gonna look at 3 plus 4 very differently now.
I'm always gonna connect it to that street I'm walking down in New Orleans.
So the point is, if you have Gleason 3 plus 3, about 20% or 30%, at least 20%, more like 30% of people that I call and say you have prostate cancer, I'm going to say that's the bad news. The good news is you only have a small volume of Gleason 3 plus 3. You can watch that. So this same analogy, roll around the corner, there's 2 7th graders. right? There's two 7th graders roll around the corner in their swimming trunks, and they say, "I want your watch and your ring." I'm like, dudes,
Get out of
two
here.
7th graders? I'm not giving you my watch and ring. The only thing you can get is the tip of my boot.
On your behind.
So, but if you roll around the corner
Sure.
and there's, let's say, 7 7th graders, seventh
Well,
graders,
there you
and
go.
they want your watch
You
and your
getting
ring.
jumped, yeah.
I'm like, let me polish that ring for you.
Right.
I mean,
So
that's-
that background that Dr. Hall was talking about is pretty significant. If there's something going on in the background, then you'd be more concerned.
And
than
the volume.
thing
And
that's
the
going on
volume.
with the front.
So what matters in the biopsy are how many cores are involved.
right.
You take 12. It's a very different picture if 1 out of 12 is involved versus 11 out of 12.
That's right.
Absolutely.
So the number of cores and then the percentage of cores. If you've got 2 cores with 5% of tissue, or you've got 1 core with 5% versus 4 cores with 100% of tissue,
Right.
that's saying something very different. So the scoring system matters, the number of cores that are normal versus involved matters, and the percentage of the core.
So some
matters.
people would say, if you have any Gleason 4, in my analogy, you run into someone who has a knife. Are you going to leave that alone? You're probably not going to leave that alone. Someone come up to you with a knife, you're probably going to freely give up your wallet and your ring. Someone comes up and they're small percentage of Gleason 3+3s, 2 7th graders. You're not giving up your wallet. What about 2, MMA wrestlers?
Yep. Yeah,
I'm giving
they
up
don't
my
have a
wallet.
knife,
So
but
that's
they-
a high,
yeah,
high
got it.
percentage of the core involved with cancer.
Mm-hmm.
I represent that as saying 2 big muscle-bound guys.
Right.
It's not just 2 7th graders. No, 2 linebackers.
High percentages. Yeah.
They're going to get my watch and my ring. No problem.
Help us understand the Gleason. So if the percentage is high in the core, that's like the MMA guys.
That's right.
Let me say something.
Yeah,
I'm sorry, just to
because this
clarify, because I didn't go through it enough. So your Gleason score, the lowest is 2.
Okay.
The highest that you can have is 10, because remember we said there's 2 scores. So the lowest is 2 if it's 1 plus 1, right? Because you can't get any lower than that. The highest is 5 plus 5, because the scoring system is 1 through 5.
Okay.
The majority of Americans, if they are diagnosed with prostate cancer, they have a 6. But then you can have men who also have 3 plus 4 or 4 plus 3 or higher. We just don't see 1 plus 1 anymore, 1 plus 2, 2 plus 2. So usually we're starting at 6. I haven't even seen
So
a
where
5.
would diagnosis start then, you guys?
So the first thing the pathologist says is there prostate cancer or
Present.
not?
Okay.
If there's no prostate cancer, you have no Gleason score.
Okay.
Okay, then it comes back, it says this tissue is benign, it's normal. So if the pathologist looks at all these cores and says, I do see prostate cancer, the next order of business is, what is the score? And so then they go about giving each core a score.
How aggressive is it? How aggressive is your cancer? That's the score.
Right.
Got it.
And so if you ask me, Doc, what's the most important prognostic factor? Your PSA?
I would ask you that. You know
Your
I would.
Gleason score? If your exam is abnormal, what's the most important thing? It's the Gleason score.
Is the Gleason score.
How aggressive it is.
That
It's how aggressive
that
it is.
So, empowering our listeners, empowering our men, what would you be recommending to them? What would you leave with them from this conversation
So
today?
the recommendations oftentimes say if you clearly have a 10-year life expectancy, or let's look at it in reverse. If you have so many other medical problems where your 10-year life expectancy is in serious question, unless you have a palpable nodule or very high PSA, you probably could be observed. No need for a biopsy because you probably wouldn't treat that man. But if you are of an age at risk for prostate cancer, you should get a PSA. If your PSA is elevated or if your exam is suspicious, probably your next best step is to get a biopsy and find out if you have cancer.
That's right.
Even if you have cancer, a good 3 out of 10 will be able to observe the cancer because it's not enough to treat.
That's it. That's it.
And I would also say, since we're talking about biopsies today, that there are a lot of men who have had a biopsy in the past for an elevated PSA, and they're wondering, well, do I have to just go under another biopsy again, or is there something else that we can do to determine if I really have prostate cancer or not. Because my PSA, they've taken it again, is still elevated, but I've had a biopsy or I've had 2 biopsies. What more can we do? I want those men to know that there are other tests out there to help determine if they should have another biopsy, if they need one. We have an imaging test called a 3T MRI to evaluate the prostate gland. So if you do undergo a biopsy, at least you can target areas of concern and determine where we should target biopsies next time. Because again, when you're sampling the prostate, you're only sampling a small amount. So where you target is important. But then there's also another test that you can do from the past biopsy specimens and look to see if there's evidence in the biopsy specimen that you might not see cancer there, but there's some changes going on that really put that person at risk for saying somewhere in that prostate gland there is indeed cancer. So that's like looking at the neighborhood, what we call the background, the whole neighborhood. We can look at the neighborhood around the biopsy, and the neighborhood will tell you if there's something going on.
Right.
And so
they don't have a problem snitching.
That's right. And so you can get a test back to say, I think there really is some cancer that was not found on the biopsy, because remember that this is not a full sampling of the prostate gland. This is taking a sample from different areas of the gland, and that sample doesn't turn out to even be 3 or 4% of the whole prostate. So that's why you might have to have a second or third biopsy. Sure. But there are tests to help know if you need another biopsy and where to biopsy.
So what I gather is that we're getting to the place of knowing. The PSA lets us know there's a bark. And then we're pursuing, there's other tests, there's exams, there's things that we can do to find out what kind of dog we're dealing with.
That's right.
Whether or not we want to go after that ball.
Give it the pit.
Leave it alone.
Pitbull, you don't got it.
We'll just observe. We'll just observe and see how that goes.
Right.
Fantastic. A great understanding of how we diagnose prostate cancer. Not we, but y'all. Diagnose prostate cancer and what we are facing as family members of those, our loved ones, our men who are trying to find out, need the information, have an elevated PSA, or haven't even taken the screening yet. Take the screening. The ultimate goal is knowing. We can start with the PSA screening and determine where to go from there. Make sure you share that information with every man you know, especially if they're 40 and over and African American. We want to be sure that you come from a place of knowledge. We welcome your questions and comments and look forward to seeing you next time on the next Our Healthy Men. Our Healthy Men, the Prostate Cancer Question and Answer radio show. The Prostate Cancer Coalition emphasizes the significant advancements in the detection and staging of prostate cancer, and that PSA is just one of many options available to help you make an educated decision. The Our Healthy Men radio show is made possible by Siteman Cancer Center and the Barnes Jewish Foundation, with your hosts, Dr. Lannis Hall, radiation oncologist with Siteman Cancer Center, and Dr. Arnold Bullock, urologic surgeon with Washington University. I'm producer Jade Harrell. To listen to the full episodes, for resources, to find a doctor, or to learn about events and free screenings in the St. Louis region, visit prostatecancercoalitionstl.org. Now you can listen to all of our shows on the iHeartRadio app from anywhere. And of course, we want to hear from you. Send us your questions, your comments, and especially your personal story, knowing that yours can be a help to others. Our Healthy Men is another positive production of Rare Gem Productions. Thanks for listening.